So thank you for the invitation. I'm glad to be here with you to talk about Triclip therapy. So as Thibault said, I'm an echocardiographer. I'm the echocardiographer who do the screening for Triclip therapy and transcatheter tricuspid therapy. And so today we'll talk about echo screening for Triclip. So to begin, we need to talk about some anatomy because, as you know, the anatomy of the tricuspid valve is complicated. So the simple part is, the tricuspid valve is the atrioventricular valve on the right side on the heart, but you have to know much of that. So I hope you can see my little hand, white hand here. The first thing you need to know is that the position of the aortic valve is always anterior. So first you look to the aortic valve, and the commissure that is close to the aortic valve is always the anteroseptal commissure. So if you are able to find this commissure, you are able to find the anterior leaflet and the septal leaflet. The septal leaflet is always close to the septum. Okay, and the last one is the posterior leaflet. So keep in mind, the aortic valve is always anterior, and the anteroseptal commissure is close to the aortic valve. Second point is about papillary muscle. Maybe you know there is 3 papillary muscle on the tricuspid, but you have to focus on this one, the bigger one with the white star here. It is the anterior papillary muscle, and it's very important for Triclip therapy. Why is that? Because first, it's a big muscle, so you can easily see it in echo, and it is a good landmark. Secondly, it is a papillary muscle that give chordae both for anterior and posterior leaflets. So it's like a border between anterior and posterior leaflets, and if you can see it, you can see where is anterior and posterior leaflet. Last important point is on tricuspid morphology. I'm sure you know this paper from Rebecca Ann that shows that only half of the tricuspid valve are really tricuspid. About the third is quadricuspid with 4 leaflets, and it's very important to know what morphology you have before planning a procedure. Why is that? Because it is easy to treat a tricuspid valve tricuspid valve with 4 leaflets, and it's more difficult to treat a tricuspid valve with 5 leaflets. So you have to assess this part of the tricuspid valve. So now let's go to the echo. So to be simple, you have to standardize your echocardiography, and you will use 2 kinds of view. And it's very important to always do your screening with that views, and to always do your procedure with that views. So the first views, and it is the most important view from my point of view, you can't do a Triclip therapy without this view. It's the transgastric short axis view. So you can find it at deep transgastric with anteflexion of the probe, and you need to have this kind of view with the whole valve, and here you can localize your leaflet. So once again, here you have the aorta, so the aorta is anterior. Here you have the liver, so it's posterior. Here you have a commissure. It is a commissure that is close to the aortic valve, so it is the anteroseptal commissure. I have my septum here, so this is septal leaflet, anteroseptal commissure, anterior leaflet, and here you have the posterior leaflet. So what can I do with this view? First, I can assess my morphology. It is with this view, you can be sure you have 3, 4, or 5 leaflets. Second, and it is very important to plan your procedure, it is with this view, you will localize your regurgitation. As you can see here, there is a regurgitation between septal and anterior leaflet, but most of the regurgitation is between septal and posterior leaflet. Okay? Here, you can also size your coaptation gap. And you will size your coaptation gap in this view in the position you will target with your clip. So here, if I do a triclip therapy, the regurgitation is between septal and posterior, so I think I will have to treat this regurgitation by clipping posterior and septal leaflet. So I will measure my gap like this. It's very important. With this view, you can plan your procedure. It's another patient. Here you have a coaptation gap between septal and anterior leaflet, so I can guess that during my procedure, I will have to put 2 clips in this position. It's very important to do the planning. During your procedure, you will use the transgastric short axis view to do the clip. You're comfortable with Triclip and you do the orientation with 3D. In tricuspid valve, 3D is not always good, and so we prefer to use that kind of 2D view to do the orientation, and you will choose your target zone with this view. You will be able also during the procedure to do the grasping. Here it is between septal and anterior leaflet, and as you can see, you can perform a grasping with this view. I will show you again. So look at the septal and anterior leaflet from now. So they are mobile, they are moving. You retract your clip here, and you will see. So they stop to move. They don't moving. They are in the arm. You can close your clip, and you can do your grasping. Okay, so it's a way to do the grasping. From my point of view, it's not the best way, but you can do the grasping. And at last, after putting a clip, for example here, you can assess the result and decide if you want to put 1 clip more. In this case, I'm okay with you. Maybe we will plan to put another clip between septal and posterior leaflet. So it is a first view, and once again, it is a mandatory view. You can't do a triclip therapy without having a very good short axis view on the tricuspid valve. The second view, it's very similar to mitral valve. We will use the biplane and to do some commissural view. So you can find this view at mid-esophageal, about 60 to 90 degrees. The kind of and you need to find this kind of, you need to find the big papillary muscle here. You need to split your tricuspid valve in 2 leaflets, and you need to have in the right side of your image the aortic valve and the pulmonary valve. So in this kind of view, you can be sure that the right side of the view is anterior because you can see the aortic valve. And here you can be sure that this leaflet is anterior because it is close to the aortic valve and it is separated by the big papillary muscle from the posterior leaflet. So with this view, you can know what is anterior, what is posterior, and where is the anterior leaflet, where is the posterior leaflet. Now you will put the biplane, and you can have a leaflet which was behind. So here, if I put my biplane here, in the anterior part, the anterior leaflet, here I have septal and anterior leaflet. If I put my biplane in the other side of the big papillary muscle, I can have septal and posterior leaflet. Okay, so it's a different view, but it's very useful for what? First, to do your orientation, to do your guidance during the process with you will and to know what is anterior, what is posterior, what is septal, what is lateral. And you can talk and say, okay, I think you need to go more lateral, more posterior, and you will use this kind of view. So it's very, very helpful. And last but not least, you can do the grasping in this view. And from my point of view, it is the best way to see the grasping because it is very similar to Triclip, and you can see very well the leaflets in the clip. So I recommend you to use this view to do the grasping. You can improve a little this view by putting your probe deep in the esophagus, just close to the stomach. And in a deep esophagus, you can have a very good definition of tricuspid leaflets. So now you know everything about anatomy, you know everything about key view in echo. It's easy. There is view are not very easy to find, but there is only two view. Once again, transgastric, short axis, and bicommissural. And now, what about eligibility criteria? So you remember what Thibault said. The goal is to clip two leaflets with a Triclip. So you need to catch the leaflet with a clip, and you have to keep in mind that the bigger clip we have is the XT, and 12 to put 9mm or leaflet in the system to have a good grasping. So you can guess, you can't treat big coaptation gap. It's very important to understand that. You can't treat big coaptation gap. So there is a table, a famous table you can find in internet. It's the same thing than in mitral and the Everest criteria. And you can find this with eligibility criteria. There is three types of patients. There is patients who are ideal for the therapy, patient we will be challenging, but you can do it, and patient you not to do you need to know you can't do it. So ideal patient is patient with secondary tricuspid regurgitation, small coaptation defects, regurgitation which is central or anteroseptal. From my point of view, most important, good echocardiographic window. You need to see everything. No pacemaker lead, and of course, normal RV function and no pulmonary hypertension. You have patients, you can't treat them with Triclip. They are the patient with big coaptation defect, more 7 or maybe 10mm, very eccentric jet, and very important, insufficient echographic ring visualization. If you can't see the tricuspid valve, it's a nonsense to do a Triclip. Of course, if you have a pacemaker lead who induce the tricuspid regurgitation, you can treat it, and it's more clinical. There is no pulmonary hypertension or severely reduced RV function. And in fact, treat a patient with a moderate coaptation defect, pacemaker lead, but no significant interaction. So let's everything together with some clinical cases. So my first patient is a classical tricuspid valve. As you can see, there is 3 leaflets, anterior ear and posterior ear. Is very like anatomical book tricuspid. And the regurgitation, if you see here, is central and a little anteroseptal. It's severe but not massive or torrential. And the coaptation defect, you can see it is a little one, less than 3mm. So this kind of patient are ideal cases for Triclip therapy. Little coaptation defect, central jet or anteroseptal jet with very good echographic window, you can treat them because it will be very easy to see the grasping, you know what you do, and you only have to treat the anteroseptal commissure. You do a bicuspidization, okay, and every time you have very good results. No regurgitation. So it is the best kind of case. You can find this kind of patient. I'm okay with you. It's not the patient who are the most sick, but in this patient, the therapy works very good. A new patient, a very different one. So here, the morphology of the tricuspid is a little different. So it's a quadricuspid. From my point of view, there is a septal leaflet here, an anterior leaflet, and two posterior leaflets. The coaptation gap is 5 millimeters, so it's not very big, but it's not a little one. And the regurgitation is okay, anteroseptal, but mostly posteroseptal. Here, commercial view, you can confirm everything. Here, I cut in the posterior part, so I have septal and posterior leaflet. I confirm my coaptation defect here with most of the regurgitation. And here, I cut the anterior part, so here I have septal leaflet, anterior leaflet. Here, there is regurgitation, but the main regurgitation is posteroseptal. Okay, as you see, with the two key view, transgastric and commissural view, I can see everything in the tricuspid valve and I can do my procedure. So what do you think about this procedure? This patient, it's challenging, but you can do it because you have a coaptation defect. It's moderate, it's 5 millimeter. Your jet is mostly posteroseptal and you can see everything. So you can do it. The point here is that you will need to treat septal anterior first because there is regurgitation, and after that, septal and posterior leaflet. You will do clover. Most of the time, with this technique, you will have good results. Another patient here, it's important because are like this. And here you can see there is a mechanical mitral valve with the big shadow effect, big artifact here. So it's very rare to can perform a Triclip on a patient with a mechanical valve because of the artifact. And as you can see here, we can see very clearly the tricuspid valve. We can't understand very well the regurgitation. And the second point is there is a pacemaker lead who interacts with the septal leaflet. So these kind of cases are bad cases for tricuspid therapy. You can see, and for me, it's the most important point. And secondly, you have a pacemaker induced tricuspid regurgitation. So now, in 2022, you can treat this patient with Triclip. And a last case, so here, images are not so bad, but there is 2 points you need to note. There is a big coaptation defect between septal and anterior leaflets, okay, more than 10 millimeter. It is the first point. And the second one is here. If you look at septal and anterior leaflet on the bicommissural view, you can see they are like retracted. There is a part of rheumatic disease. So in this kind of patient, you can guess it will be impossible to catch the leaflet with the clip. So you can't do this kind of patient, and You find them here, large coaptation defect, but also severe leaflet thickening, and especially rheumatic patients. So I agree. I agree with you. It's a problem because it's um, it's very common to find patients with rheumatic disease and tricuspid regurgitation and this kind of tricuspid, and to find this kind of patient with medical mechanical mitral valve, but we can't treat them with Triclip for now. So my take-home message are to do the screening and Triclip therapy procedure, you need to have good images, and the key views are the short axis view and commissural view. So it's the first step. You need to have good images. Without good images, you can't do. If you have good images, you can discuss the patient, and for the Triclip therapy, you need to have good leaflets, normal leaflets, and not a too big gap. And if you don't have that, you can treat. And just last slide, to keep in mind, if you begin a program of Triclip therapy, you need to find this kind of patient. And I think your first 10 to 20 cases need to be ideal cases for Triclip, because the procedure is very complicated. It's long, and it will be feasible with ideal. If you begin with challenging or not to do patient, clearly it will be a nightmare. So thank you for your attention.